All right, welcome to The Explainer. Today we're diving into something that can be, absolutely terrifying, but is so often misunderstood. We're talking about acute pericarditis, and that really specific, sharp chest pain it brings. Okay, let's get right into it.
So, for a lot of folks, it all kicks off just like this. Completely out of the blue, with a symptom that, immediately sends those alarm bells ring.
Right? Sharp, sudden chest pain. The first thing that jumps into your head is this a heart attack? And of course, that's a terrifying thought. Your mind just starts racing, and getting to an emergency room feels like the only possible thing to do. And look, you should always take chest pain seriously, but it's not always what you think it is. Get this, about 5% of all ER visits for non-heart attack chest pain are actually because of the very condition we're talking about today. That's a pretty significant chunk, and it makes it a really common puzzle for doctors to solve.
Okay, so first up, a pain in the chest. Let's really try to put this pain into perspective. When we say acute pericarditis, what are we actually dealing with here?
And this chart really gives us some great perspective. I mean, look, while something like musculoskeletal pain is a super common reason for chest pain, you can see acute pericarditis right there on the map. It's a known, distinct cause that doctors are actively looking for, right alongside the really serious stuff like acute coronary syndrome.
So what is this thing exactly? Well, think of the pericardium like a custom-fit protective case for your heart. It's this thin, two-layered sac, and it has a tiny bit of fluid in it that lets the heart beat smoothly without any friction. Pericarditis is just the fancy word for when that protective sac gets inflamed and really irritated.
All right, section 2, inside the inflamed heart. Let's zoom in a bit and see what's physically happening inside the body that's causing all that sharp, intense pain. It's basically a chain reaction, right? First, there's some kind of trigger. A lot of the time, it's just a common virus. That kicks off the body's inflammatory response, releasing these chemicals called cytokines. Now, these cytokines make the blood vessels in that heart sac leaky, so fluid starts to seep into that protective space. And then, for the final step, these sticky proteins called fibrin get laid down, causing the two layers of the sac to get all rough and start rubbing against each other instead of gliding smoothly. That friction, that's where the pain comes from.
So what kind of triggers are we talking about? Well, the list is actually pretty long. It can be anything from autoimmune diseases to trauma. But honestly, for most people who get this, the cause is either a simple viral infection, or in a whole lot of cases, it gets labeled idiopathic, which is really just the medical way of saying, you know what, we're not exactly sure what caused it. Okay, on to section 3, solving the medical mystery. This is where the real detective work begins. For any doctor in the ER, telling this pain apart from other really serious conditions is absolutely critical. And to do that, they're on the hunt for a very specific set of clues.
And here they are, the 4 classic clues. First up, the pain itself. It's usually described as sharp and what they call pleuritic, which just means it gets way worse when you take a deep breath or cough. Second, and this is a huge giveaway, the pain actually gets better if you sit up and lean forward. Third, a doctor might hear a really unique sound with their stethoscope. And fourth, the ECG, that's the heart tracing, it shows this very specific widespread pattern of inflammation that looks totally different from the kind of localized pattern you'd see in a heart attack.
So let's talk about that sound for a second. It's called a pericardial friction rub, and it's this high-pitched, scratchy, almost squeaky sound that's perfectly timed with the heartbeat. I mean, it is the literal sound of those 2 inflamed layers of the heart sac rubbing together. It's a dead giveaway for pericarditis, though, not every single patient will have it.
And here is another incredibly powerful clue. This quote nails it. Radiation to the trapezius ridge is considered to be specific for pericarditis. Basically, if that sharp chest pain also travels up to the ridge of your shoulder muscle, your trapezius, that is a very specific sign. Why? Well, it's because the same nerve that connects to the pericardium also connects to that muscle. It's just a fantastic little diagnostic hint for doctors.
So how did doctors rule out the big one, a heart attack? Well, the clues just don't match up. The pain from a heart attack is usually described as a crushing pressure, not as sharp pain. It tends to radiate to the arm or the jaw, not that shoulder ridge. And the ECG changes,
They're localized to one specific part of the heart, whereas with pericarditis, the changes are all over the place, or diffuse.
And the detective work doesn't stop there. They also have to rule out another suspect, a pulmonary embolism, which is a blood clot in the lungs. In this case, the patient's history is a major clue. Pericarditis often shows up after you've had a virus. A pulmonary embolism, that's more associated with risk factors like being immobile after a surgery or a long flight. There's also a handy blood test called a D-dimer. It's usually high if there's a clot, but normal in pericarditis.
All right, section 4, the road to recovery. So once the mystery is solved and the diagnosis is locked in, the whole focus shifts to getting better. And the good news is, the treatment plan is usually super effective and pretty straightforward.
The plan is really a three-stepper. Step 1, rest. This is crucial. You've got to avoid any strenuous physical activity. Step 2, medication. The main treatment is a combo of anti-inflammatory drugs, like high-dose NSAIDs, plus another medication called colchicine, which is great at reducing inflammation and, importantly, preventing it from coming back. And then step 3 is tapering. Once your symptoms are gone, usually in about a week or two, you slowly, gradually reduce the dose of the medication.
And this is the really reassuring part. Even though it starts off in such an alarming way, the vast majority of people with acute pericarditis don't even need to be admitted to the hospital. They can be managed safely and effectively right from home.
So, what happens after that first acute phase is over? Let's talk about the long-term picture, including some of the potential complications, in our final section, beyond the acute phase.
Now, while the prognosis for most people is excellent, doctors do keep an eye out for a few things. Sometimes, a little too much fluid can build up around the heart. That's called a pericardial effusion. Very, very rarely, that can lead to a serious emergency called cardiac tamponade. For some people, the pericarditis can come back later, and in really chronic cases, it can cause the pericardial sac to get scarred and stiff. But I really want to stress, these are not the typical outcomes.
So, who are the folks that do get admitted to the hospital? Well, doctors are on the lookout for these specific red flags. A high fever, a large amount of that fluid around the heart, or, just not getting better after a week of treatment. Those are all signs that a case might be a bit more complicated and needs to be watched more closely.
So, what's the big takeaway here? Well, it's that while any sudden chest pain needs immediate medical attention, no question about it, it's also empowering to know that there are different possibilities. Acute pericarditis has its own unique fingerprint, right? Its own clues, its own treatment, and for most people, an excellent outcome. The goal isn't for you to diagnose yourself, of course, but to understand. To know that with the right medical detective work, a moment of absolute terror can be turned into a clear, manageable path to recovery. It kind of makes you wonder, what other common symptoms out there are often mistaken for something far more sinister?